Assalamu alaikum. My name is Dr. Rizwana Salik, and today I am going to present to you the topic of pleural effusion, since it's quite common and it's very important that you know and you discern the cause of pleural effusion. So, effusion is happens when the patient presents with the accumulation of the fluid in the pleural space between the parietal and visceral pleura, and there is an imbalance between its formation and its absorption. So normally we have 8.4 ml of the fluid present in the pleural space, in which WBCs are 1700 and 75% macros with a 23% of lymphocytes. The protein content of the normal fluid is that of 15% of the plasma proteins. It originates from the systemic circulation of the pleural space and it absorbs into the lymphatic system of the parietal pleura. And normally there's an equal formation and absorption rate, which is 0.01 to 0.02 ml per kg per hour. So either the lymphatic obstruction is there or the protein content is less, which will cause the accumulation of the fluid in the space and will cause the pleural effusion and patient becomes symptomatic. So now coming to the causes of pleural effusion, we may have thoracic causes and extrathoracic causes. I have named few of the causes which are common causes of the pleural effusion as a presentation. So congestive cardiac failure, it gives a transudative pleural effusion. Liver cirrhosis, pulmonary embolism gives a exudative pleural effusion. It may also give a transudative pleural effusion. Nephrotic syndrome presents with the transudative effusion. So difference between exudative and transudative I'll be mentioning in next slides. And peritoneal dialysis, superior vena cava obstruction, mixed edema, thorax, these are all the causes of pleural effusion. Neoplastic diseases are very common, and the first presentation of the patient is with the fluid presence of fluid in the pleural space. So in the late stage of the malignancy, patient presents the pleural effusion, and from there we establish the diagnosis. Then there are a variety of infectious causes including bacterial and viral and fungal infections with the parasitic infection. In our setup, parapneumonic and tuberculosis are the most common causes of exudative pleural effusion. Then there are fungal, viral, and parasitic infections, which are also not very uncommon. Pulmonary embolism may give rise to pleural effusion. Mostly it is exudative but may present with a transudative effusion. Then there are extrathoracic causes which give rise to pleural effusion, namely esophageal perforation, pancreatic disease, intra-abdominal abscesses, diaphragmatic hernia. Patient present with the post-surgery with the pleural effusion, endoscopic vessel sclerotherapy, and liver transplant. Patient after surgery also present to us with the pleural effusion. Collagen vascular diseases are also important causes of the pleural effusion. Few of them are rheumatoid arthritis, stomach lupus erythematosus, Sjogren's syndrome, vaginous and Chevreul syndrome. So these are also not an uncommon cause of pleural effusion. Post-coronary bypass surgery, patient also present the transudative type of pleural effusion, and asbestos exposure, sarcoidosis, uremia, Meeks syndrome, and yellow nail syndrome all present with the pleural effusion. Trapped lung due to any cause like collapsed lung, intra-endobronchial collapse, endobronchial mass, endobronchial TB. It may cause trapped lung and the pleural effusion, passive pleural effusion. And additions in the pleura may also cause trapped lung, therefore pleural effusion. And post-radiation patient presents with effusion. Then there are post-cardiac injury syndrome, presence of blood in the pleural cavity. Iatrogenic injury like repeated aspirations causes effusions. Ovarian hyperstimulation syndrome, pericardial diseases mostly present with the transudative effusion, and presence of chyle in the pleural space due to lymphatic obstruction can cause pleural effusion. Not to forget, drugs like every other disease causes pleural effusion. Few are nitrofurantoin, dantrolene, methisargide, bromocriptine. procarbazine, and amiodarone. So we must rule out the drug history from the patient, that effusion may be caused by drugs as well. So how do we diagnose a patient with a pleural effusion? His most important is history, then we examine the patient. So in history, most common thoracic symptoms are shortness of breath, cough, plus minus fever, weight loss, lymphadenopathy. Patient presents with these kind of symptoms, and then we examine the patient and know the cause of the effusion. So for effusion to be present, to produce shortness of breath, it has to be massive. Minimal effusion may not be noticed by the patient as a symptom of shortness of breath. Uh, so in examination, there will be dullness to percussion, and vocal resonance will be decreased with decreased or absent breath sounds. Most importantly, we must locate the trachea. In massive effusion, trachea is shifted to the opposite side, and we must drain the effusion if the patient is that symptomatic. And from extrathoracic point of view, we must examine the patient overall. So these are the few examination points that will point towards the cause of effusion. Like if we have distended neck veins with S3 gallop and peripheral edema, the cause may be heart failure. With the right ventricular heave and sinus tachycardia on ECG will point towards pulmonary embolism. We also must look for lymphadenopathy, hepatosplenomegaly to know the cause, such as neoplastic disease or maybe tuberculosis. Ascites will favor hepatic cause, and a patient with a fever and signs of consolidation, most common cause would be parapneumonic effusion. So now that we have a history, we have examined the patient, now comes investigation. The most initial investigation is X-ray chest. We do it in 3 views, frontal, lateral, decubitus, depending upon the amount of fluid in the pleural space. So if it is 75 ml, the fluid is in the subpulmonic space and it obliterates the posterior sulcus only. Fluid increases to 175, it obliterates lateral costophrenic sulcus. If it is more than that, that is 500 ml, it obscures the diaphragmatic contour, and 1000 ml will be visible as amount of fluid present to the fourth rib on the chest X-ray. And decubitus radiographs and CT scans are the ideal positions and ideal scans to rule out even minimum effusion, that is 8 to 10 ml of the effusion is picked up by the CT scan. So that's also very important investigation for us apart from X-ray. We also nowadays use ultrasound because of the utility that it can differentiate between a free and a loculated pleural effusion. Free fluid will be anechoic, that is a black area within the lung field, and pleural loculated pleural effusion will be presenting with the septas and echoes within the anechoic area. So ill-loculated effusion versus solid masses can also be differentiated with the help of ultrasound. And apart from X-ray, this investigation is also very cheap and bedside. We can easily do it without waiting for the patient to move to X-ray department. Then we can also perform ultrasound guided thoracocentesis in order to prevent complications of repeated aspirations and pneumothorax. CT scan, as I told, that it will tell us about the underlying parenchyma, what's the lung disease is like, and the amount of effusion if it is present, because it is the most sensitive one. Now that thoracocentesis, we perform guided or blind. What we look for? First of all, we look for the color. So if it is a bloody color of the effusion, it may indicate malignancy, which is most common. Pulmonary embolism, trauma, or pneumonia may sometimes give rise to bloody effusion. Hematocrit, with 1 to 20% of the hematocrit in the fluid will represent malignancy, pulmonary embolism, and trauma. And more than 50% of the hematocrit will indicate hemothorax. If the appearance is turbid, it is due to either presence of cells, debris, or lipid content which is high. Now, centrifuging the fluid will be done if we are suspecting a chylothorax or a pseudochylothorax and to know the lipid content. So if the triglycerides are more than 110, will represent a chylothorax, and triglycerides of more than 50 with a cholesterol level of more than 250 in the fluid will represent a pseudochylothorax. Cellular content within the fluid may also give rise to the clues towards the diagnosis. So the neutrophil, if they are more than 50%, will be representing a parapneumonic effusion, pulmonary embolism, and pancreatitis. Further investigations will tell about the cause. Like for pancreatitis, we also do amylase and lipase in the fluid. Then lymphocytes, if they are more than 50%, will present presence of cancer, TB, or post-cabbage. Eosinophils are also very important. If they are more than 10% within the fluid, it presents hemothorax and pneumothorax. Cancer, tuberculosis, repeated thoracocentesis also give rise to eosinophilic pleural effusion, asbestosis, paragonymous, Sturge-Strauss syndrome, and drugs including dedrolene, bromocriptine, and nitrofurantoin, and all other drugs that we previously discussed also give rise to eosinophilic type of pleural effusion. Putrid odor represents anaerobic infection. For that, we do gram staining and culture to know the organism and treat the patient. AFD smear and gene expert is essential part. We do send culture gene expert smear and expert in the pleural fluid. Ammonia-like odor will represent the urinothorax. So we've been talking about exudative and transudative. When we see the report of the pleural fluid, we must know on the basis of cells and on the basis of protein that whether it is an exudative type of fusion or is a transudative type. So more than 3.5 grams of the protein in the fluid will present an exudative type of effusion, and less than 2.5 grams will be in a transudative effusion. For transudative, we just treat the cause, but for exudative, we have to be particular about the diagnosis and the treat accordingly. So there is a difference in management also. Therefore, we must know what is the effusion like, exudative or transudative. But what if the effusion contains the protein between 2.5 and 3.5 grams? For that, we apply Light's criteria. For exudative effusion, we should know the LDH level, protein ratio of the serum to the fluid, and LDH ratio of the fluid to the serum. So fluid serum protein ratio should be more than 0.5 to be to call it as an exudative type of effusion. The ratio of serum protein to fluid protein should be less than 0.5 for it to be a transudative type of effusion. Similarly, the ratio of LDH of the serum to the fluid should be more than 0.6 for exudative effusion, and should be LDH ratio of the serum to the fluid should be less than 0.6 for the transudative effusion. Fluid LDH should be more than 2/3 of the upper normal limit for it to be exudative, and fluid LDH, that is pleural fluid LDH, less than 0.67 of or the 2/3, less than 2/3 of the upper normal limit would represent a transudative type of effusion. Now that we have diagnosed the effusion on the basis of cells and proteins, that it is an exudative or transudative, we should think about the causes. Transudative would be most commonly in congestive cardiac failure, liver cirrhosis, pulmonary embolism, nephrotic syndrome, drugs, and all other causes that we just discussed. For exudative effusion, that is protein content more than 3.5, we look for the cells, pH, smear, cultures, glucose, LDH, cytology, amylase, lipase, ADF or TB, ANA, and RA factor will all depend upon the causes that we are suspecting in the patient. Glucose level is very important because just to give an example, as we said, that parapneumonic effusion is the most common type of exudative pleural effusion. So if the glucose are less than 60 or 40, we put the tube in the patient. So that's the treatment and that's the utility of glucose. Similarly, if glucose less than 60 are found in other causes of pleural effusion as well, that is exudative effusion, malignant TB, hemothorax, rheumatoid arthritis, Sturge-Strauss syndrome, SLE, and paragonimasius. These are all the causes of low glucose level in the fluid. We also do LDH. Uh, LDH we do for the for application of Light's criteria, and it is prognostic also. So if LDH is repeatedly increasing in the fluid, we must be aggressive that the disease is more and the patient is getting sick. And if LDH after treatment is going down, that is a good prognosis. We also do cytology if suspicion is that of malignancy. Because of the yield of cytology in the fluid is not that high, we go then for the definitive diagnosis to the blind needle biopsy or medical thoracoscopy, which are more sensitive tests. So I've given you a know-how about the pleural effusion, its formation and its normal composition, then uh, changes in the disease processes, how do we approach on the patient on the basis of history, examination, investigations. We discussed the investigation, but this is the last sentence that says no diagnosis is ever established, approximately 10 to 15% of the patient. So even if we have done the biopsies, biopsies also come inconclusive to us sometimes. So in that case, these are the few cases where we do not find biopsy to be conclusive also. So in that case, we review the patient overall and then review the diagnosis. So thank you all. This is about it. It was a small presentation of pleural effusion. Goodbye.